Welcome to Kian's Kiosk, insightful ruminations on the continuum of care.
Hello, everyone. I'm really delighted today to be welcoming my good friend, Greg Buchert. Welcome, Greg. And Greg and I have known each other for, how long has it been, Greg? Over a decade now?
It really has been, Kian.
So I'm so delighted you made time for us today, and I'm really looking forward to our conversation. I'll do a quick, probably a poor man's job of intro, and then you can tell us more about your background. But what's fascinating for me about Greg is he's been involved with, as a medical doctor, of course, in our healthcare system, but on the administration side as a chief medical officer, and always on the Medicaid side, I believe, right, Greg?
Always on Medicaid and Medicare most of the time.
So this brings a whole new expertise and outlook on healthcare, much of which really I don't have great visibility. So I'm really excited to learn from you today and have our listeners also learn. So tell us about your background and what drove you into medicine, Greg, and also what drove you from practice to really multiplying your benefits through administration and positions of management.
I had the opportunity to help launch CalOptum, one of the first Medicaid Managed Care Plans in California. It gave me an opportunity to take care of thousands of people at a time as opposed to the one by one that I was doing in the emergency department. And over the years, between being a chief medical officer, a chief operating officer, or a CEO for several plans, I was able to never lose sight of the fact that I was a physician taking care of patients and individuals that lived in families or lived in communities, but to leverage that concept to try to take care of many people at once. And so that's what drove me into managed care, drove me into taking care of both low wealth individuals in the Medicaid program and seniors in the Medicare program. And it's been an extremely rewarding career where I think I've been able to make a difference.
So I know you personally, Greg, to have that big heart and make a big difference in people's lives. One of my favorite questions to doctors who I know is, when does the system ever get in the way of that heart? And the reason you went into healthcare and to provide services and do good. In your experience, when you came across those situations, how did you handle them? Was it like pushing a rope uphill? Was it more fulfilling because you could find ways to do things? For someone on the outside, what's been your experience in that area?
It's a great question, Kian. And truly the system does get in the way at times. And a lot of it focuses on the attitude of the individuals. When I first got started in this whole area of managed care, it was in the bad days of managed care where, I found nurses giving themselves high fives whenever they could deny something. And granted, this is probably 30 years ago, but it was an opportunity for me to step in to say, no. Just think, if this was your child or your parent or your sibling, what would you do? And try to help people think sensibly and sensitively about doing the right thing. And then there was the practical aspects of, there is things such as utilization review on the managed care plan side, where the whole goal objectively is to try to make sure that people get the right care at the right place at the right time. And unfortunately, there's sometimes that there are people who abuse the system, and so safeguards are put into place which unfortunately penalize the majority because of the the greed on the part of a couple of people that are working the system to their benefit.
So we hear about crisis in Medicaid, and tell us what that is, if that is, and what is being done, what should be done, how you feel about it. Educate us on what it is that we're talking about.
And so right now the looming crisis in Medicaid is the fact that during the public health emergency enacted during COVID, the federal government paid a bonus to states for Medicaid members on the condition that they didn't disenroll anybody. They want to make sure everybody had access to care. And with the public health emergency ending shortly, those individuals will all have to go through a redetermination process to ensure that they're eligible for care. A very reasonable thing, very appropriate thing, but we know from past experience that whenever somebody has to go through what's sometimes a very onerous process, it might be a 20, 30, 40-page application, for somebody that has a grade school education, it's challenging. It's challenging for me with a lot of degrees behind my name to fill out that kind of paperwork. And so a lot of people won't get that access, won't have the insurance, and once again, we'll see all too many people crowding into emergency departments, displacing those who truly need emergency care. I'd say that's the biggest crisis coming up in the near future.
I mean, this is a big deal, right? So if we have certain percentage, I don't know what the percentage is going to be, 5, 10, 20% falling off the Medicaid rolls, and then the system has to still take them in, like you said, an ER. The cost of that, there's no prevention in that model, and we all pay for it as taxpayers. It's just one hand throwing it out, kicking the can down the road, basically, and then everybody else pays. So is there any plan? This seems like too onerous to be ignoring. Who's paying attention to this?
There's a lot of people that are paying attention to it, and specifically, there are activities going on at the federal level as well as at the state level. And then you might imagine, whether it be an individual provider or a health plan, they all want somebody who is supposed to be eligible legitimately to be enrolled. And so there really are a lot of outreach activities ranging from public service announcements to texting campaigns to newspaper campaigns, and working through community-based organizations to try to provide assistance to individuals who want to and need to and should stay enrolled in the Medi-Cal and Medicaid program.
Now, is Medi-Cal, in the case of California, but Medicaid in general, is it purely based on income, or does it include other things like mental capacity or other issues like maybe physical challenges?
Yeah, it does include other things. So the primary thing that you think about is somebody that comes from a low-wealth family that doesn't have an income high enough to qualify for either the exchange plan or commercial insurance or have insurance through an employer. So income is one of the criteria. But individuals can also qualify if they are meeting certain criteria for disability, and that could be mental or physical disability. And it's not just the Medicaid program or social services that determines somebody for Medicaid, but it could actually be through Social Security. And somebody, could be qualified for both Medicaid and Medicare at an age less than 65, where we tend to think a lot of people are eligible for Medicare, but in reality, these individuals who are either Medis or dual eligibles, or I often refer to them, the average age is around 65. So you know that there's actually a fair number of people that are less than 65 that are qualifying for Medicaid and for Medicare.
Wow. So I was going to go to dual eligibles next, and if these numbers drop, then the dual eligible numbers drop as well. And is that true, first off, right? Because if one of the eligibilities drop, the other one's going to not be dual.
So yeah, a lot depends on how somebody became eligible for Medicaid. So if they did it through their state, then they have the potential of dropping. If one gets Medicaid through Medicare because of disability, then they're actually enrolled in Medicaid for life because of that disability. And so there are a number of duals that will not lose eligibility during this redetermination process.
Interesting.
When the public health emergency ends.
How about a PACE program, for instance? How does that work?
A PACE program, PACE is an acronym for Program of All-Inclusive Care for the Elderly, is what I would argue is the most sophisticated Medicare program. There's very specific criteria for being eligible, and it's something on the order of having 6 to 8 chronic conditions, and one has to have Medicare. But it's a program that provides a lot of services for that individual, ranging from transportation, often to a facility where somebody can get. You can think of that as adult daycare, where they get a chance to socialize, eat with others, often get a lot of their medical appointments or even pharmacy services at the PACE site. And so they really are wonderful, wonderful developments that serve the sickest of the sick very, very well with great outcomes.
Yeah, we had earlier guests at Kian's Kiosk was Dr. Jenny Chen Hansen, who you may know. So she was the CEO of Unlock, and way back when, that's when PACE program started. So it's a model that I believe in a big way because it aligns the organization with the person's interests, which is what you do always as well, which is you care about the person getting well. And like you said, sometimes the system might get in the way, so solving that problem is all of our challenges, especially the folks who are the most in need and have income challenges, maybe disability challenges. And unless someone takes care of them, then they show up in ER. Is there anything else other than ER versus, safety net, basically? There's no other way.
The good news for individuals is, there is federal law called EMTALA that says that anybody who shows up to an emergency department has to, at a minimum, get a medical screening examination. And, that results in them being triaged into you're sick or you're not sick. And if you're sick, you need care, you're going to be seen in the emergency department. And so the emergency departments don't have the ability to deny care to individuals who show up there. But that isn't the only solution. One of the things that, many people access, but others may not know about, are the federally qualified health centers. These are community clinics, community health centers. They go by a lot of different names, but they are also there to provide that safety net for individuals to get care. And indeed, they get paid, by the federal government to provide care to the uninsured. And so it's something that is a way to not only get care, but also get continuity so you can go back over and over, and there is much more of a preventive focus that occurs in an FQHC as opposed to an emergency department.
Wow, fantastic. I had no idea about that. And is it like, let's say, one per county, or it depends on the size of the population or the state? How do you find those?
When you look at the larger urban counties, there's actually quite a few in any large geographic area. And they often are the only provider in some of the most rural or frontier areas. And then just one of the things that there are also similar things such as the rural health centers or the Indian Health Service clinics. But as far as finding them, they're referred to as federally qualified health centers, community health centers, and it would be, and there's an organization in each state called the Primary Care Association that tends to be the organizing element for the community health centers in their area, in their state or in their community.
That's amazing. So, and that reduces costs probably greatly because, like you said, if there's any kind of preventative measure versus somebody just walks into ER, we're talking a huge difference in cost as well as quality of life.
Yeah, and the interesting thing about the FQHCs is that they often have broader services than you might find at a general practitioner or other primary care provider. They often have mental health services, they often have dental services, often have case management, and may have other specialty care available as well.
So tell us what happens when somebody does go into ER. My understanding is basically if it's a private hospital as well as if it's a county hospital, in both cases, like you said, the federal law requires you have to be taken care of to some basic minimum level. And where does the bill go?
It all depends on what kind of insurance somebody has.
No insurance. They walk in with no insurance.
If they have got no insurance, that's a problem because those are the people that end up having to pay the most, if you will, because they're going to get a charge for the facility, they're going to get a charge for the emergency department physician or other provider, and any of the services. This is one of the reasons why healthcare is one of the leading reasons for bankruptcy. And so you can imagine that if you don't have insurance and you get a bill for thousands or tens of thousands of dollars from an emergency department visit, it's obviously a horrible situation for that individual. And my advice to anybody who might be in that situation would be to contact the hospital to see if they can work out some arrangement, some payment plan, because if you figure that an insurance company is often paying 20, 30, 40% of the billed charges, it's obviously dramatically less than what an individual is paying for if he or she gets that bill for charges at the usual rate.
And if the person can't pay, then it just goes into the cost of business, and that's where insurance rates go up and cost of everything else goes up to a large extent, right? It shows up somewhere.
It shows up somewhere, and so there's hospitals that absolutely have to write off a lot of this care. But in the meantime, you've kind of wreaked havoc on a family, its finances, and potentially their credit for many, many years to come.
So I want to shift gears here, Greg, and fast forward to your challenges and passion nowadays. You're doing a lot of consulting. You're working and helping a lot of startups in healthcare. And so how is that going, and what is it that you do, and what's exciting in that field for you?
Yeah, actually, it's very exciting. And so I'm working with a couple of different angel investing groups. And it's not so much that I'm investing in lots of companies as much as it gives me an opportunity to see the future of medicine, the future of healthcare. The companies will sometimes see problems that I don't even recognize and come up with solutions. And so it's really exciting to see these types of activities going on. And I'm probably seeing between 10 and 15 companies a week. Some of them are, Me Too activities that are just saying, hey, somebody else has a good idea, or they're making money, so let me try to do that also. But other ones are incredibly creative. One of the things that I really enjoy doing is if I find a company that meets my basic criteria of they are improving care, they're lowering cost, and they're applicable to a Medicaid population, I often look to see how I can help them grow and develop their company. There's not a lot of people that are former health plan executives that are available to help them understand how to approach a health plan, how to get their services paid for, and populations that they can potentially work with. And the other thing is I really enjoy being a connector. I might see a company that's great in one area, but I've seen another company or know of other opportunities. And so I'm very happy to introduce certain companies to former colleagues at the Medicaid plans if I think that their solution is going to make a big difference. So it's been a lot of fun and very rewarding.
Well, I've personally benefited from that. Independents benefited from that, and I'm always appreciative to you for that. One of the things that the listeners should know is when you and I first met, we were pretty young as a company, and it was a long time ago. And I always remember that you were kind with your quick and really deep understanding of what we do and how we're different. And you were super supportive, and you made connections back then for us. And we, not that we lost touch, but we hadn't interacted for a while, and we happened to get together more recently. And immediately, when we had a chance to update each other, you went straight back to that, and you were kind with your thoughts about where we are and what we could do. So that hasn't changed in you, and I know you're making a big impact to all those companies.
When you find a company that's great and doing wonderful things like Independa, that's who I really want to help. You're making such a difference in the health of individuals. You're absolutely checking off all my boxes of improving quality, lowering costs, applicable to a Medicaid population and all other populations as well. And as recently as today, when I saw one of the startup companies, I said, this is going to be a great solution for Independent to add to its very, very robust set of programs that it offers. And so I'm always looking out for those opportunities to be that connector still.
Well, we appreciate that. Anything you think is of value gets to the top of the line for us, so I really appreciate that. So, Greg, how do people get in touch with you, by the way? So if somebody is listening and they say, boy, this is too good to be true, this person with all this experience actually enjoys helping the right companies in his wheelhouse, how does one go getting in touch with GSB Health Management Solutions?
I'd say the easiest thing is just to send me an email. And my email address is just my name, Greg Buchert, and that's Buchert 1527 at gmail.com. Well, they're also able to connect to me through LinkedIn.
Perfect. Anything I should be asking you that I haven't? Anything you want to ask me?
Yeah, let me ask you, there's so much going on right now in the area of telehealth, remote patient monitoring, and the use of digital tools, and especially the empowerment of individuals to take care of themselves. Where do you see the future for Independa and with all these types of recent activities?
We can be on a tablet or a computer or a laptop, of course, but we really feel that TV as a digital health device gives that person in their home a big leg up, and also gives the providers, if there's a provider involved, doesn't always have to be, could simply be consumers that are interested in having a better platform for health and wellness. But if there's a provider, gives them a better platform to engage with that individual. So when you talk about, for instance, telehealth, how does that matter on a TV versus a computer? We've had therapists or doctors tell us the fact that somebody can be sitting on a couch and chatting with them, the fact that they could see the person, and their body gestures and postures versus just the face and the nose, as they chat with them, let alone in family therapy or couples therapy. They want to see, the body language of one versus the other as one is talking. So it's just a more effective platform to engage in health and wellness. Another easy, simple example is doing exercises, whether you're doing exercises to a video that's in front of you on a big screen and you have room to look, let alone when you get older with macular degeneration. For older adults, it's even that much more compelling to be in front of that big screen. Or if you have a trainer, like one of our upcoming partners is a training system for fitness, and they can actually draw things right on the screen and make an imaginary box and you jump over the box. Or for physical therapy, they could draw a line and say, hold your hand up. And so everything is so much easier with this digital health device, I'm calling the TV, versus if it was on a computer, you won't even see that small line. So that's one aspect, is just the form factor of the TV. The other aspect is what you talked about, where we see things going. We think a whole ecosystem approach to providing curated services that are valuable to the person in their home is the winning model, versus somebody doing searches on, how do I get this kind of service, or how do I get a trainer? Because there's so much advertising, there's so many opinions, there's so much content that it's hard to figure out, what's true and what's not, what's good for me. On the other hand, if you get WebMD, health videos around 16 categories, from cardiology to pharmacy to mental health to oncology and so forth, close to 800 videos that you can't get on the internet. So we feel having a curated set of services and benefits and wellness applications on your TV has that extra advantage, where not only is it the form factor, but an ecosystem. And then finally, not having to do with Independa, is this consolidation of really the home as the place where we have to become healthy and well. And for the system to also recognize that. Our chief medical officer, Dr. Richard Della Penna, shared with me that early on in his career, and he's been a partner for running on 13 years now, I think, with Independa. But he shared with me early on that he learned health happens when someone leaves his office. And so he was always interested, as the head of older adult care for Kaiser Permanente nationally, where he always was interested in what's happening in the home. So Independa, to a large extent, is really dedicated to the same mission and vision of how do we help you be where you are safer, longer, more comfortably. And the beauty is healthcare is really coming to that same model versus the episodic, you're with a doctor, or you're in a clinic, or you're in ER, or you're in a hospital and you go home. That's somebody else's problem. So I think that's the big picture answer is folks like Amazon and Apple and Google, consumer companies, cable satellite companies that have relationships with consumers, offering more and more healthcare. You could see Amazon is offering more and more healthcare services. And I think if we look back 5 or 10 years, there will be a huge opportunity for someone like Apple with the watch, with the AI technology going into these speakers, with TV-based engagement, all that tied together with smart homes. What happens if there's even simple things, security things, like if my ring and the front door gets turned on, what if it shows up on my TV and I get to see that person automatically? So everything gets tied together in a platform. So that's where I think the vision is. And one last comment, as you mentioned, remote patient monitoring. So I think, again, in our view, that should be part of a system. For instance, how much easier would it be if you can have survey questions or answer some questions that are real time based on your biotelemetry feedback on the remote patient monitoring, instead of having a dedicated tablet next to your bed for that. Lower cost, higher engagement, more effectiveness, and also the two companies, like we're talking with a number of RPM companies that want to do that exactly on the TV.
It's interesting. I talked earlier about providing service to the right person at the right time in the right place. As a physician, we often get deluded into thinking that what we see in that 10 or 15 minutes of an exam once every 6 months or 2 years, that gives us total insight into an individual. And that's so short-sighted, and that delivering care to people where they are, when they want it, is so valuable. And then the other thing I really like about what you do at Independa is the cultural sensitivity, the fact that you can deliver your services in a number of languages. And so with the changing demographics of not just the United States, but other countries, that's so important. And I applaud you on pursuing that.
Yeah, thank you so much. Well, we feel both passionate and fortunate to be where we are. And really, healthcare is coming to us. It was never my intent early on to be a part of any kind of medical system. We're not still a medical company. But the beauty of medicine nowadays is the vision that you've always had and Richard has always had and we've always had is really healthcare happens in the home, and it doesn't have to be diagnostics, and it doesn't have to be some FDA-approved thing. If I step on a consumer scale and I see that 10% of my weight just went up in the last 2 days, it'll be nice for someone to be monitoring that very cost-effectively, passively for me, and raise a flag for the right people if I have, let's say, congestive heart failure. Maybe that's, fluid building in my lungs. So even as health-related as a situation like that is, it could be a consumer approach that then the medical establishment gets involved in. So, out of 100,000 people, maybe 5,000, maybe 500 need to be attended to that day. So the cost really goes down and engagement goes up with systems that are consumer-oriented, in our view.
And I applaud you on what you're doing at Independent. I remember learning about it, many years ago, and was just so impressed that you're providing services to the people who need it, where they need it, when they need it. And so that's a wonderful thing.
And with a platform everybody knows how to use. We really appreciate that, Greg. Well, Greg, it's such a pleasure to be chatting with you, get this quality time with you, and to move along this path with you. And we appreciate your time at Kian's Kiosk, and I know the listeners do as well. I learned a lot.
Well, thank you for the opportunity for joining you today.
It's my pleasure. Thanks for listening. We always would love to hear your thoughts and suggestions. You can leave them for us at podcasts@independa.com. That's plural, PODCASTS, @independa.com. And make sure you follow us on your favorite podcast platform. I'll be ruminating with more thought leaders on future podcasts and do hope to see you then. In the meantime, stay healthy and happy.